Welcome to section 10 of the Falcon Physician Review's anatomy review portion. Now we're going to be moving into the lower limb, and we're going to start by discussing some of the lower limb organization. Now there's a lot of things that you've learned in anatomy over the last little while, and I think it's important that you make basic decisions about things. And I like to use the idea that there's only bones, muscles, tubes, cords, and organs within the anatomical system. So all of the details that might have slipped away from you are not always as crucial as you'd think they'd be, as long as you can make a good basic decision about some of these organizational components. So when you think about tubes, they tend to have a lumen, and they can be arterial, venous, or lymphatic. And if you think about cords, those don't have a lumen, and they would be tendon, ligament, and nerves. And predominantly nerves is where you want to spend your focus. So, as we move into the limbs, we know already that the upper limb and the lower limb are basically just like one another, in that the upper limb is basically a lower limb turned over 180 degrees. And it's these two characteristics that make us unique in our abilities to walk upright and to have the fine motor skills in our hand that allow us to coordinate and manipulate the world around us. But we have a lot of similarities between these two that we want to pay attention with. We'll start with the lower limb, and then we'll move through into the upper limb a little bit later. So what are some clinical facts that you want to know about the lower limb? Why should you spend some time on it? Well, it's one of the most common sites for joint injury, which would be the ankle, tendon rupture, which would be the calcaneal tendon, peripheral arterial disease, the problems with DVTs is a major lower limb problem, and then the orthopedic problems associated with some of these joints, including the knee and the hip. It's also the most common area for grafting of muscles, which would be the gracilis, of bone, which would be the fibula, nerves for sural nerve graft, tendon, which would be the plantaris tendon, is basically an extra piece for surgeons, and then vascular grafting for the great saphenous vein. Lower limb fractures are going to be where we're going to spend our first portion on the limbs and the bones that are associated with those fractures, to make sure that we have an overview of those structures. So we have overuse fractures, traumatic fractures, and pathological fractures. Each of those can be divided up into different types. For the traumatic fractures, the simple, compound, comminuted, spiral, green stick, buckle, or known as torus fractures, and even telescoping fractures. A lot of these are traumatic in nature. And then we have lower limb fractures that are more common in males as long as they're under 45, but they become more common in females when you get above the age of 45. Just got a couple examples here where you can see a patellar fracture, and it's been screwed together. You can see both an anterior and a lateral view, and then you can see the fifth metatarsal styloid process fractured off in the Jones fracture, sometimes also known as a dancer's fracture. So when you'd expect to see that kind of thing would be someone that has everted in a rather violent way and then tried to right themselves by contracting the lateral compartment of the leg. So you might see that in a scenario where there's a dancer in one of the questions. What you want to start with any of the limbs is a regional organization. So if you break it down into regions, we have the hip joint, knee joint, and ankle joint. Above the hip joint we have the pelvis. Below the hip joint but above the knee we have the thigh. Below the knee and above the ankle we have the leg, and then finally we have the foot. And at each of those areas we have a major joint, which is going to be important to understand. I like to organize it into compartments as well. So there's 4 compartments I want to think about around the hip and the thigh. There's 4 compartments that I want to think about around the leg, and there's the 4 layers of the foot that you can break it down into for the understanding of those areas. What are the compartments? Well, the thigh and the gluteal region, you want to have the gluteal, and then the thigh can be divided into 3, which is the posterior, anterior, and medial compartment. The leg gets divided into posterior compartments, which has a superficial and a deep, as well as an anterior and a lateral compartment. And then finally, the four layers of the foot, and of course the dorsum of the foot, which only has one muscle on it. So we'll break that down just basically to understand the coordination and organization of that for injuries. What are the nerves that are distributing to each of these areas as we break them up? Well, we have the thigh and hip region, which is going to be involved with the sacral plexus. Then we have the leg, which is also involved with sacral plexus. And we have the foot, which is sacral plexus. But if we look at the thigh, we have the anterior and medial components of the thigh that are going to be lumbar plexus. So most of the lower limb is going to be sacral, with a little bit of above the knee stuff distributed by lumbar. It's important to understand each area's compartments and how they're broken down. So we'll look simultaneously at the thigh and the leg. Around the muscle compartments of the thigh, we have the fascia lata, and the extension of that below the knee is known as the crural fascia. They're really the same thing. Both will divide into intermuscular septa, and we've talked about three compartments of the thigh itself, plus the gluteal region we don't want to forget about, and then the four layers or compartments of the leg. So on the lateral side, that fascia lata thickens in the thigh to be the IT band. Then in the anterior compartment, we have basically two muscles. In the anterior compartment, we want to think about them being innervated by the femoral nerve. When we move to the medial compartment, we have 5 muscles we want to remember, and those are done by the obturator nerve, with a couple exceptions in that there's 2 muscles in the medial compartment that get dual innervations. One from the anterior, which is femoral, and one from the posterior, which we're going to find out is the tibial component of the sciatic. In the posterior and gluteal region, we want to have 6 lateral rotators, 3 gluteal muscles, and 1 tensor fascia lata, and then we have the 3 hamstrings. Sometimes you'll want to break the hamstrings down into 4, as I've done here, just to remind you that the short head of the biceps femoris actually gets a different nerve from the other 3 hamstring muscles. And it's this posterior and gluteal region that you're going to have the sciatic nerve, which has tibial and common fibular components, and then also the superior and inferior gluteal nerves, which will do the gluteal region. As we move into the leg, you have the lateral compartment, all of which is done by superficial fibular nerve. Anterior compartment, which is done by deep fibular nerve. These come off of the common fibular. And then the posterior compartment, both the deep and the superficial posterior compartments are done by tibial nerve. In the deep posterior compartment, you can see that there are 3 muscles that are underneath the soleus, but there's 1 muscle above the soleus, which is why I've put it as 3 plus 1. The plantar foot has 4 layers, and all of them are supplied by the tibial nerve, which will then branch once it gets into the foot as the medial and lateral plantar nerves. Now, as we move into the bones and joints of the lower limb, we have 31 bones in each limb: an os coxus, a femur, patella, tibia, fibula, and then the calcaneal bones, the talus, the cuboid, navicular, and then 3 cuneiforms to make up the tarsal bones. We have 5 metatarsals, numbered 1 through 5, from medial to lateral in the case of the foot, whereas they'd be lateral to medial in the case of the upper limb, and of 14 phalanges, which we also have in the upper limb. As we look at the bones and joints of the pelvis, we're going to do some quick review of this, so if you're familiar with it, please move through quickly. And if you're unfamiliar with it, please spend a little bit more time making sure that you have some basic foundational information at your fingertips. So the os coxae can divide up into 3 components. all of which fuse together embryonically, or at least during the growth phases, at the acetabulum. So there can be fractures of the acetabulum based on the fusion points. There can be imperfect formation of the acetabulum because of the embryology that happens there. But basically we have three components: ilium, ischium, and pubis. Posteriorly PSIS, anteriorly ASIS. The sacroiliac joints have both anterior and posterior components, which are fibrous ligaments that run between those various things to make it very stable. High congruity amongst that joint itself. And then we want to remember we have a pelvic brim. We'll talk more about that a little bit later on. And we have a pubic symphysis, where the two os coxae combine together to finish the pelvis itself. So three components: two os coxae and a sacrum. Between the ASIS and the pubic tubercle, remember the inguinal ligament runs in a vertical plane. And this is just a reminder of the different components and the bones and the type of joints there are. If we're looking at the clinical importance of the hip joint, we have to remember that there is a acetabulum, which is a ball and socket joint, which also has a labrum to even improve more the congruous connection between the acetabulum and the femoral head. The unique thing about this joint is that it has a very thick capsule that has three components of the capsule, each coming off of the os coxae to reinforce it. It also has the ligament of the head of the femur, which has a vascular supply to it, and there's not many joints in the body that have their own vascular supply within the joint itself through a ligament. But what this means clinically is if there's a fracture of this joint and that ligament is damaged and there's bleeding inside of the joint, you will definitely have osteoarthritic change as a result of that. As we look at the outer portions of the capsule, you can see that there's an ischiofemoral coming from the ischium to the femur. Then we have this Y-shaped ligament of Bigelow. That's the thickest of them, known as the iliofemoral ligament. And on the underside, we have the loosest of the three ligaments, which would be the pubofemoral ligament. And since it's loose, it both allows for range of motion in an abducting scenario, but it also allows for inferior dislocations of the hip. The blood supply to the neck of the femur is crucial for maintenance of the bone, and that is through the medial and lateral femoral circumflexes, and the most important of those two is, of course, the medial femoral circumflex vessel. There is a branch of the obturator that comes through the ligament of the head of the femur, or also known as ligamentum teres femoris. An occlusion of these vessels that make the articulation of the head of the neck and neck of the femur can cause osteonecrosis. After about the age of 25, the head of the femur, that ligament and its blood vessel start to close down slightly, so that is less perfused after the age of 25 than it is prior to the age of 25. Most, as I said, the dislocations tend to be inferior, but the posterior can also be a dislocation point. Those tend to be in very high impact scenarios, such as car crashes. So we've got this ball and socket. It's got 3 degrees of freedom, which allows for the flexion, extension, abduction, adduction, and median lateral rotation, as well as circumduction, like all 3 degrees of freedom in ball and socket joints. It has a strong capsule, and I'll let you read through the rest of those main points about the hip joint itself. As far as clinic, be aware that the pelvic fractures is a leading cause of death after the insertion of car airbags, because people are no longer dying of the head injuries, they're actually dying of the pelvic injuries that they used to never get to before they would deal with the head injuries. And since this is a pelvic ring, there's many different ways that it can be fractured, but one thing that's important is that a ring tends to break on 2 sides. Therefore, pelvic fractures, be suspicious that it's broken in 2 places. the problems with it being broken, of course, is that there's some major vasculature around some of these common fracture sites which can be damaged, and an enormous amount of blood can be leaked into the abdominal pelvic cavity very quickly, and this can often lead to death. In this image, you can make out many of these portions of the SI joint, the pelvic brim, pubic symphysis. Look at the angle in the pubic arch and the lesser and greater trochanter, as well as the pubic tubercle and the ASIS. If you look at the trochanters, a lot of times in younger people there can be avulsion fractures from these areas, and they'll actually pull off the growth plate that is in association with some of these tubercles. Let's start with a question that focuses in on this kind of information and how it might be used. A 79-year-old African-American woman is admitted to hospital after falling in her bathroom. Her right lower limb is laterally rotated and 2 inches shorter than the left. Radiographic exam reveals an intracapsular fracture of the femoral neck. Which artery is most at risk for injury? The answer is medial circumflex femoral. Even though the lateral circumflex femoral is involved in the supply of the joint, it is the medial circumflex femoral that's the most crucial, and should this be damaged, will oftentimes lead to osteonecrosis as a result of avascular blood supply. Now here you can see the 3 different areas of hip fractures or fractures of the femur, and you can see a neck fracture, which is known as a subcapital or intracapsular. Those will bleed into the capsule and they result oftentimes in avascular necrosis, therefore they typically will need a hip replacement. Intertrochanteric, also known as extracapsular, are at less risk of avascular necrosis because they bleed into the thigh, and they can usually be pinned. And then fractures of the thigh itself, or spiral fractures, will just need pinned. The presentation is important because it's classically laterally rotated and foreshortened due to the lateral rotator activity and the spasm of the thigh, which is still attaching to the greater trochanter. As for dislocations, there's no separation of those things, and the medial rotators are more powerful, therefore the dislocated hip tends to rotate medially on presentation. The paradoxical fracture is something you may run into, although it's going to be less common than it used to be. They typically thought that hips would be broken by the weight of the individual as a result of osteoporosis, and they would break their hip and fall down, whereas now they've discovered that most hips that do fracture indeed are from them falling down and then breaking their hip. If we look at the knee joint, 3 articulations, the tibia, the femur, and the patella. It's a modified hinge joint, meaning it has 2 degrees of freedom, but it's also susceptible to injury because it has poor congruity, especially compared to something as stable as the hip. There are intrinsics, which are called the cruciate ligaments, and extrinsics, which are the collaterals in the capsule, and they're all going to assist the capsule in support of that. And then there's the fibrocartilaginous menisci, which are involved in impact absorption. The menisci is attached to the medial collateral ligament, so the medial meniscus is much more stable than the lateral meniscus, both by attachment and by reinforcement. The movements, of course, are going to be flexion and extension with some slight medial and lateral rotation, and those are associated with locking and unlocking of the knee, where the locking is done by passive movement of the weight of the limb as it's extended. The popliteus is an active unlocking muscle, and it will rotate the femur laterally. Here you can see some basic structures to help you review the anatomy. I'm going to move right past this, and we'll pick up with some other things and take a little bit more time on the cruciate ligaments. And you must understand how the cruciate ligaments work and the relative actions that will affect one over the other for the USMLE. If we look at the femoral side, you can see their proximal attachments, which will be the anterior and posterior cruciates, labeled by A and P. Notice how the anterior starts laterally and the posterior starts medially. Their names are given, however, on where they attach relative to the tibia. So the anterior is so named because it attaches to the anterior tibial plateau, and the posterior attaches to the posterior tibial plateau. When you think about their attachment, we can put posterior in with this blue rectangle, and it crosses from the femur to the posterior aspect of the tibia, which will be checked when there is motion above the knee from behind the femur, and it will be checked when there's motion from in front of the tibia when you're below the knee. If you apply too much force in those directions, the posterior cruciate will be stretched and therefore damaged. Opposite is true for the anterior cruciate in darker blue. The anterior cruciate comes into activity when the tibia is hit from posteriorly below the knee and when the femur is hit anteriorly from above the knee. So this crossing is why they're called cruciate. They have a cross-like shape. So the anterior will check tibia movement forward from the femur, and the posterior will check tibia movement posterior or from the anterior side of the femur. Now, oftentimes you'll see an anterior cruciate damaged, and this is a red flag that you should be aware of, that it will have very quick swelling, and that's largely because of the blood vessel that runs inside the anterior cruciate ligament, unlike a posterior cruciate, which will typically have a slower swelling period. The other thing that's important as far as these injuries, which you need to remember, is that the posterior cruciate tends to be damaged on hyperflexion, and the anterior cruciate tends to be damaged on hyperextension of the knee. Couple cases. A young man involved in a head-on automobile collision had his knee flexed and hit the dashboard of the car. He was later found to have a major instability of the knee, in that his tibia could be moved posteriorly relative to the femur. What ligament was likely damaged? And using the information we just talked about, you would probably pick posterior cruciate, because the anterior cruciate would have been damaged if the tibia moved anteriorly relative to the femur. And the lateral and medial collaterals will typically be damaged when there's a varus and valgus force. Strains include things like the ACL injuries occur where there's a potentially where there's a valgus force or rotation and hyperextension, and the femur will slide back on the tibia. PCLs, as we mentioned, will be more associated with hyperflexion injuries and the femur sliding forward on the tibia. The MCL, medial collateral ligaments, are going to be reinforced through the knee capsule and is more stable of the ligaments compared to the lateral collateral ligament, and therefore is more often injured. In general, you'll find that whatever's more stable will take the brunt of a force load and will reach its threshold faster than something that's more mobile. And since the lateral collateral ligament is not stabilized by the capsule, it's less often injured. Not to mention the fact that you tend to have more difficulty getting into the medial side of the knee in general, and therefore it's just less likely to be strained. The meniscal injuries, therefore, are going to be in association with the MCL because of its anchor to the medial meniscus. And that stability that it offers also increases its potential for being injured. Because the lateral meniscus is more mobile and has a more closely approximated attachments on the tibial plateau, therefore it has more mobility and is less likely to be injured. When you get a meniscal injury, they can be torn from their attachment sites, they can have frayed edges through wear and tear, or they can have bucket handle tears, which would be from condylar loading and rotation. And a lot of times when somebody has a meniscal tear, one of the red flags is that they will complain of it feeling like it locks or needs to pop. And then they bend it and straighten it again, and that will unlock it. They'll also have significant trouble when they try to do any deep knee bending, as if to pick up keys off the floor. One of the classics that's oftentimes tested would be the unhappy triad, and that involves damage to the medial collateral ligament, the ACL, and the medial meniscus, which are usually as a result of an externally applied valgus force or a rotation. Here you can see the classic clipping injury, which would be a valgus force applied to the lateral compartment or the lateral side of the knee, which would make the distal limb, the leg and foot, go in a lateral direction, thus valgus. That's going to cause gapping, and it will result in the medial meniscus, medial collateral ligament, and anterior cruciate being damaged. A lot of times damage to the knee is going to result in osteoarthritic change, and one of the symptoms, or one of the ways of managing the symptoms associated with the pain from osteoarthritis, is in a total knee arthroplasty. Here you can see some of the changes to the joint structure where there's significant osteophyte formation, some pitting of the cartilage itself, and significant pain on function that are typical of osteoarthritic change. One of the things you need to be clear on is the differences between osteoarthritis and rheumatoid arthritis. Remember, you have a normal joint space without an inflamed joint capsule or synovial space. And then on rheumatoid, it's more of an inflammation-based autoimmune disease. Therefore, the joint is swollen and hot, and will oftentimes cause the compression of the joint over time to have bone erosion around the cartilage, and this can lead to deformities. Whereas osteoarthritis is something that you see less inflammation but more wearing of the hyaline cartilage, so that you get bone-on-bone activity, which is quite painful. The difference that also exists is that the osteoarthritis, both are degenerative, but the osteoarthritis tends to be a weight-bearing joints that will be applied first, and it may not be bilateral. There's also a loss of joint space in the imaging of osteoarthritis, whereas rheumatoid arthritis is going to be an autoimmune disease, so other organs are often affected. So you can have pleurisy, coughing, pericarditis, generalized fatigue, bilateral because it's an autoimmune disease that affects the body systemically, and it tends to be at the distal joints with long morning stiffness. Oftentimes osteoarthritics will say that they have morning stiffness, but they oftentimes can get over it if they get up and get moving slowly. A third portion of arthritis is gout. Gout can have serious effects on the joint itself. It's an inflammatory event because of onset of extreme joint pain, and there's going to be an associated increase in uric acid. This will result in heat, swelling, redness, and oftentimes skin lumps, which can continue to calcify and deform the joint. It's exacerbated oftentimes by being overweight and also alcohol. It tends to affect the extremities, more exclusively the lower extremities and the toes especially, but can also affect the hands, as seen in this bottom image. So we have several risk factors that make you more susceptible to gout: renal diseases, obesity, diabetes, and anemias. In general, you want to look at joint congruity and spacing. Images are becoming more popular on the USMLE, and there's both pathological as well as normal images. When you're looking at a normal joint space image, you should see a fairly even distribution of the joint space, whereas in an abnormal or pathological image, you'll see approximation because of the loss of joint space and the cartilage that's intervening. If you're looking at MRIs, this one is showing that there's several bursas around the knee. There's the prepatellar bursa, which is going to have a history of a friction or superficial swelling in the stem. Infrapatellars suprapatellars tend to be deeper and have overuse as part of the history that you'll hear about in the stem. And the swelling seems to be deeper. All of these will have heat associated with them oftentimes, and there's an effusion test that you can do to see whether or not the swelling is a bursa or an intracapsular swelling. Here are some structures that I've labeled just to remind you of the basic anatomy in this region, and we'll move past that fairly quickly. Q-angle, something that you'll sometimes hear about in the USMLE question banks, and that refers to quadriceps angle, which is really two intersecting lines. The first line runs from the ASIS through the center of the patella, and the second line runs vertically through the center of the patella. The angle formed between these two bisecting lines is the Q-angle, or quadriceps angle. This is a larger angle in females because of the wider placement of the ASIS, and a narrower angle in males with, of course, gray areas in between. But the males tend to be 10 degrees or so, whereas the females tend to be a little bit wider at 12 to 15 degrees. The significance of having wide hips and a large Q-angle is that it makes you more susceptible to patellofemoral syndromes, which oftentimes are results of poor tracking of the patella in the femoral condyles. And with this poor tracking, either through muscular imbalance or widened Q-angle, it can lead to pain and chondromalacia with the breakdown of the posterior surface of the patella. The patellar grind test will oftentimes make people elicit a pain response, and there's also positive theater sign that you should keep attuned to, and this sign is when people feel the need to straighten their legs after being bent for relatively short periods of time, although they'll feel that they're long times, and they'll oftentimes have crepitus associated with the grinding and the swelling as a result of the poor tracking. Look at the soleus. We're looking now below the knee. We have the proximal knee joint. There's a couple things that you're going to be interested in knowing about. One is the interosseous membrane and how there's a gap at the top of it. This membrane helps support and sequester off the different compartments of the leg, but it also allows for the passage of the neurovascular bundles from posterior into anterior. The soleal line is the attachment point for the soleus muscle, and underneath the soleus there'll be the deep posterior compartment, and above the soleal line there's still a muscle which is quite deep and get against the bone, but is not part of the posterior deep compartment and therefore not affected in a posterior compartment syndrome. And that muscle that sits above that line is the popliteus, which I always remember as because popliteus pops your knees, and that's the lateral rotator of the femur that's going to unlock the knee joint. On the distal end of the tibia and fibula, you can see the talocrural joint starting to come into effect, and this is going to be the proper ankle joint. There's both a medial and lateral malleolus on the tibia and fibula respectively, and the lateral malleolus projects more inferior and is actually on the lateral side of the ankle joint, therefore it's not a weight-bearing bone. Most of the brunt of the forces dissipated into the lower leg are going to be as a result of forces coming up through the tibia. Osteosarcoma is one of the most common child forms of cancer. It's a malignant tumor that usually develops because of the rapid growth. It's more common in kids around the age of 15, anywhere from 10 to 20, and they have equal risks until they start getting older, and then it tends to be more common in taller males. It occurs in the long bones near the metaphysis, and that's going to be the tibia and fibula and the humerus as the common sites, but typically 50 to 60% of these are around the knee. So keep your ears perked for young males, especially tall, that have a fracture of not traumatic forces, and there's a good chance that they may need to rule out osteosarcoma. Chemotherapy and surgical removal of the limb are common ways of dealing with this. Let's look at the distal leg in this lateral view. Here we can see the outline of the fibula. Here's the outline of the tibia. And now you can see the talus, calcaneus, navicular, which is boat-shaped, cuneiform, and the cuboid. Notice how the cuneiforms are all overlying one another, and it's difficult to tell one from the other at this point. The cuboid is going to be the square-shaped bone, and it will be more lateral, whereas the cuneiforms will be more medial. This is a mortise and tenon joint, which means that it's kind of a woodworking term for a well-connected joint. It is wider on the talus in the anterior position than it is in the posterior portion of the talus. Therefore, the ankle is less stable when you're plantar flexed than if you're dorsiflexed. Clinically, this plays into scenarios where you would hear people spraining their ankles when they're going downhill more often than when they're going uphill, simply because of the positioning and the stability of the ankle. When we look at the bones of the foot, it can be divided into several regions. There's the 7 tarsal bones, 5 metatarsals, and then the 14 phalanges. And then you can also look at the sesamoids on the deep surface. Here is the top of the talus, which is, as you can see, wider anteriorly than posteriorly. And then you have this line between the tarsal bones and the metatarsal bases, which would be the designation of the forefoot. Anterior to that would be the forefoot, behind that would be the midfoot, and then the calcaneus is the hindfoot. You also have a subtalar joint. We're not going to spend much time on that at this point. I want you to notice that the midline of the foot is through the 2nd digit. This is similar to, but not quite the same as in the hand, where the midline is through the 3rd digit. And they are, of course, numbered from medial to lateral, 1 through 5. Let's look at a question. During a basketball game, the center of the team goes up for a rebound, and when coming down, her foot lands on the foot of another player, sharply inverting it. She limps off the floor, having severely sprained her ankle. Which ligament is the most likely to be injured? Since this is an inversion sprain, we're looking for one of the lateral ligaments, and the most commonly sprained one is the anterior talofibular ligament. Let's move on and talk about the ligaments and which ones you can think through as far as being injured based on the method of injury. When we look at the lateral side of the joint, we can see that there's an anterior and a posterior talofibular ligament, and then there's a calcaneofibular ligament as well. On the medial aspect, there's the deltoid ligament, which can be subdivided into several points, but in general it operates as one large ligament. With sprains, you can have grade 1, grade 2, or grade 3, and these sprains of these ligaments with a grade 1 would be just a minor tear or stretch of the ligament, whereas grade 2 would be a partial tear, and grade 3 would be a total disruption. Think carefully about the stability of the joint when you're listening or reading through questions on this. Oftentimes, a grade 3 has less pain because the ligaments have been totally damaged and the nerves damaged with it, but it will have greater instability. So those two components alone will lead you towards a grade 3. You can do a talar tilt, you can do an anterior drawer on an ankle joint to see if there's stability as well, so look for those tests inside the stem of the question. Now, the method of injury is going to be important, so how it's written up is also going to give you some clues as to which injury you have. For instance, the perpendicular tendon or ligament, the perpendicular ligament to the ground, is the one that's the first one to be damaged. As an example, if you're flat-footed and someone were to step on your medial side of your foot and force you over, you would have your calcaneofibular as the perpendicular one to the ground, and it would be the first injured. In jumping, as we had in our previous question scenario, you come down in a plantar flexed position, which makes your anterior talofibular perpendicular to the ground, and again, that's the one that's most damaged in jumping. And if you stepped into a hole and sprained your ankle, the posterior talofibular would be perpendicular to the ground, and that would be the first one injured. Whereas eversion, you're thinking about the deltoid. Remember, a lot of these ligaments are much stronger than the bones they attach to, so this is a common place for avulsion fractures. Here we can see an example of a bimalleolar fracture as a result of an ankle sprain. You can see this is a very serious injury, and it basically involves total instability of the ankle itself. What can oftentimes happen in this injury is that somebody will roll over on their ankle on an inversion sprain, do a malleolar fracture, which will then cause a torsion and have a distal third of the fibula that will fracture, oftentimes spirally, and then this will cause total disorganization and instability of the talocrural joints, and then the weight of the body will push across and tear the anterior inferior tib fib ligament. These are always repaired by surgery, and oftentimes this kind of fracture is known as a Pott's fracture. So it's a bimalleolar avulsion fracture and a tibial shaft fracture. The injuries usually caused by combination of abduction and external rotation from an eversion force. That concludes section 10 on the joints and bones of the lower limb. Now we'll move on to section 11,